This is the second part of the management of the medical emergency lecture series. Today we'll be looking at some of the medical emergencies of particular importance in a dental office. We'll look at syncope, acute anxiety, seizures, asthma, airway obstruction. We'll look at chest pain, stroke, and then finish up by talking about diabetes issues that can arise. So starting off with syncope. Syncope or fainting is actually one of the most common medical emergencies that we'll tend to see, especially in a dental office. And it can be caused by a variety of different factors. In terms of etiology, it can be due to irregular heartbeats, both those that are especially slow or fast. It can be due to disruptions in blood flow or delivery to the brain due to either an obstruction or pulmonary embolism, aortic stenosis. There's a lot of different reasons there. Or it can be neural mediated or hyperventilatory in nature. Neural mediated is the one that is most common in terms of causes, especially with vasovagal reaction being the number one cause. We'll also talk about orthostatic hypotension as well. So looking at vasovagal reaction or vasovagal syncope, it's certainly one of the absolute most common causes of syncope in a dental setting. It's one of the most common medical emergencies that we'll see. And it often follows an event that's extremely stimulating to the patient, such as placement of local anesthetic or a tooth extraction or some sort of really painful procedure. And it can be in response to some sort of negative stimulus like the sight of blood or the sight of medical equipment like needles. There's a variety of reasons why vasovagal syncope can occur. We'll also look at orthostatic hypotension, which is mainly caused by a sudden change in body position, and we'll talk also about hyperventilation as well. So looking now at vasovagal syncope in particular, what we have initially is a patient who's under a certain amount of stress, and that stress is going to cause the release of epinephrine, and that's common as we see, or as we would expect, with activation of the sympathetic nervous system. That often accompanies stressful situations. And so that additional epinephrine is going to activate a lot of the adrenergic receptors in the body. So we're going to see activation of the beta-2 receptors in the skeletal muscle, and that's going to cause vasodilation within the skeletal muscle. And so what we essentially have is, over time, is we get a little bit of pooling of the blood in the peripheral tissue, specifically the skeletal muscle. Now, as that goes on, what we start to see is that pooling can be substantial enough that we're going to see a decrease in blood returning to the heart, and so we're going to see a drop in the filling pressure. And that is interpreted by the body as a hypotensive situation. Now, the heart's going to respond accordingly, and it's going to respond by increasing the rate and the contractility. So we're going to see an increase in the rate to kind of compensate for that drop in blood pressure. Now, as that rate continues to escalate, not only one of the things that occurs then is the filling time starts to dramatically decrease. And then as that filling time continues to drop, we kind of see a negative cascade effect, essentially, where the rate increases, we get less time to fill, we get less blood in the heart, and the heart's not able to move as much blood as it can if it would fill completely, and then ultimately we're not able to eject that blood throughout the circulatory system, and that's going to lead to additional, it's going to kind of worsen the hypotensive situation. Now, the other thing that we get is that increase in rate is going to stimulate pressure receptors in the wall of the heart, and then ultimately, as the heart contracts more and more and more, those pressure receptors sense that increased strength, that increased pressure, and then once it reaches a certain threshold, then we get a reflex where the heart essentially is told we need to slow down and stop. We've kind of met our maximum contractility point. And so we see paradoxical bradycardia and then hypotension as a result, because essentially the heart, slows down, and that's called the Bessel-Gerish reflex. Now, ultimately, what happens is when the heart slows down and stops contracting so quickly and so strongly, we see a dramatic drop in blood pressure, and then that's usually sufficient enough to dramatically decrease the cerebral blood flow. And if we decrease the cerebral blood flow, the oxygen-rich blood going to our brain, if that stops, the brain is deprived of oxygen, and then the patient passes out. So let's look at vasovagal syncope and some of the initial findings. And initially what we're going to see, because of the release of epinephrine, we're going to see initially tachycardia. The patient's going to be tachypnic. They're often anxious and jittery. And because of the increase in heart rate, though, you would expect that you would probably see an increase in blood pressure. However, that's kind of counterbalanced because not only do we get activation of alpha-1, which is going to cause vasoconstriction, but remember we get the activation of the beta-2 receptors in the skeletal muscle, which is going to cause vasodilation. And so essentially we kind of get a balancing out. So oftentimes they're kind of normal tensive. But you can kind of get a sense for these patients' anxiety just by looking at them. They're kind of jittery and anxious, fast talking often. Maybe they're a little sweaty. And you can kind of identify that just simply by looking at them. Now, as that cascade effect that we talked about before continues or progresses, right before they start to pass out, if you were to measure their heart rate, they become extremely bradycardic. They would become extremely hypotensive because of the sudden decrease in cardiac output. Oftentimes, the lack of perfusion, they'll be very white or display pallor. They'll be diaphoretic, and then if they're able to verbalize, they'll often complain of lightheadedness or that they feel like they're going to get sick. And you can kind of once again look at them and you know that they're just not feeling quite right. Down below you can see this is an EKG strip from a patient that we actually had in our clinic while a syncopal event was going on. And you can see the heart rate is extremely slow, somewhere around 3 to 6 beats per minute. That's extremely slow. So in terms of treating vasovagal syncope, obviously the main issue here, the reason they pass out is because of the decrease of blood flow to the brain. And so our goal here is to quickly reestablish that blood flow to the brain. And so we do this by essentially doing a couple different things all at once. The first thing we need to do is put them in the head down or Trendelenburg position, which is what you see in the diagram to the right, and simply allow gravity to assist us in increasing the blood flow to the brain. Now, the other thing we can do, because a lot of the decrease in cardiac output is due to the extremely pronounced bradycardia that occurs, we can treat this by using our vasolytic drugs such as atropine, which has got a very quick onset, and so that's essentially going to quickly reverse the increase in or it's going to block the parasympathetic activity, and that'll really kick the heart rate up substantially, and that'll dramatically increase the cardiac output. And some other things that are really useful, though, is being able to recognize this as it's proceeding events are happening, and really take steps to prevent it from occurring in the first place. So if you look at a patient and you can tell they're really anxious and really jittery and really nervous, there should be some clues popping into your head that maybe I'm going to have to deal with a vasovagal syncopal reaction. And so you can go ahead and take some steps. You can go ahead and lay them down a little bit. You can go ahead and talk to them, identify what it is that makes them nervous. And then you can think about potentially using some sort of sedation, such as nitrous oxide or oral sedation, IV sedation, etc., to really help, take care of the anxiety and reduce the likelihood of having a syncopal event. Now, let's talk about orthostatic hypotension. Essentially what we have here is a sudden change in body position that's going to cause a dramatic drop in cerebral blood flow. We often see this after moving from a seated position. If we stand up very quickly, I'm sure a lot of you have experienced that in your lives, where if you stand up really quickly, you may get a little lightheaded and kind of act and feel a little dizzy. With some patients that have abnormal or impaired sympathetic or autonomic function, that effect can be especially pronounced. And so the patients that are most at risk for this would be like really elderly patients, maybe patients that are on beta blockers. And they can have some impaired baroreceptor reflexes as well that are going to worsen or increase the likelihood of this occurring. Let's talk about hyperventilation. Hyperventilation, essentially what we have here is a extremely rapid breathing rate or respiratory rate. And remember that every time you breathe out, you're blowing off or exhaling carbon dioxide. And if we continue to overbreathe, then what we could have essentially is blow off excess carbon dioxide, and that can cause a respiratory alkalosis. Now, the blood vessels in the brain, the cerebral blood vessels, respond to alkalotic situations or alkalotic blood by vasoconstricting. And so if we have an especially pronounced respiratory alkalosis going on, we're going to get vasoconstriction of the cerebral blood vessels, and then that's going to potentially impair the cerebral blood flow, potentially enough that they can have a syncopal event, just like we would have with vasovagal syncope. Frequently, hyperventilation is associated with panic attacks. Often we see physical findings that are very similar to those found in vasovagal syncope. They can be tachypnic. That's the number one sign that we're going to see. They can be diaphoretic. They can faint. They can complain of numbness or tingling. And you can kind of see this little cycle that we have over to the right, where we have a stressor that's going to lead to increased anxiety. That's going to lead to hyperventilation. That's going to lead to a lowering of the carbon dioxide levels in their blood. And then as those CO2 levels decrease, we start to get alkalotic blood. They're going to have that tingling, that nervousness. That's going to increase their apprehension. That's going to lead to additional sympathetic nervous system activity, which is going to kind of worsen the symptoms, and then they're going to hyperventilate more. And so this can kind of feed back on itself and really worsen the overall picture. And so our main treatment with hyperventilation is certainly to prevent it from happening. We want to be able to identify these patients and intervene appropriately. And one of the best ways we can do this is really to use our good chairside rapport with patients, and we can just simply reassure them, relax them, and help manage, non-pharmacologically their hyperventilation, their anxiety. We want to really work with them to decrease their respiratory rate, and ideally what we're trying to do is increase their carbon dioxide in their blood and reverse that alkalosis. One of the ways we can do this is by having them breathe into a brown paper bag. That's going to allow them to retain carbon dioxide but still maintain oxygen levels. It's important that you do not have them breathe into a plastic bag, because obviously that's going to decrease the amount of oxygen available and they can become hypoxic. Some other things that you can certainly consider is the use of premedication or sedation with these patients. If you identify that they're anxious and nervous and potentially hyperventilating, they can be great candidates for sedation. One of the key points I want to make here is that with this situation in particular, this is really one of the rare situations where supplemental oxygen really is not necessarily needed. This is not an oxygenation issue. This is a carbon dioxide issue. So, it's not totally indicated. Now, there's nothing wrong with giving it, but it's really not going to fix the problem because it's not an oxygenation issue. Now let's talk about acute anxiety attacks. When we look at patients, once again, that are having acute anxiety attacks, it's very kind of similar in presentation to hyperventilation and to vasovagal syncope, where often we're able to identify these patients simply by looking at them. You can look at this young lady on the right-hand side, and you can tell that she's just not feeling well. She's feeling very anxious. They're developing, often nervous behavior, very quick respiratory rate, and often, increased depth. This type of hyperventilating breathing. Oftentimes they're very pale, they're diaphoretic, headache, they can be confused, etc. These are all signs and symptoms of an acute anxiety. And if we really aren't able to effectively recognize and then manage these patients accordingly, then these patients are going to be at risk for adverse events such as vasovagal syncope, hyperventilation, syncope. And then theoretically, if you really stress them, they can, and they're not able to tolerate that additional stress, they could have a myocardial infarction or potentially even a stroke. So really, our management goals here is really to reduce stress. And we do that, a lot of different ways. One of the best ways we do it, once again, is to develop and use our good chairside rapport with patients and talk them, through whatever issues they're having and kind of explain what we're going to do. And a lot of times that really does the trick. Certainly we can consider sedation or some sort of stress reduction protocol, often with sedation, to really minimize any of the worrisome issues that can happen from the additional stress. Now let's talk about seizures. So whenever we talk about seizures, really what we're looking at here is an uncoordinated massive discharge of electrical activity within the brain. Normally we have that electrical activity going on, but it's very well coordinated. With this, it's like a thunderstorm within the brain, essentially. And because we have all this, uncoordinated discharge or electrical activity going on, that can really impact the entire central nervous system. And so it can be, we can see a whole host of symptoms, including sensory or motor activity, symptoms or signs. It can lead to altered visceral function, irregular autonomic function. We can see certainly all kinds of different sensation, olfactory, auditory, visual hallucinations. Certainly abnormal motor movements. Basically any portion of the brain that's affected, the normal function of associated with that particular area is going to be altered as well. So the different types of seizures that we'll look at and talk about today, we'll talk about generalized or tonic-clonic seizures. These are often associated with epilepsy. When we think of seizures, this is what we classically think of. We'll talk about generalized or absent seizures. We'll look at simple partial and then complex partial seizures as well. In terms of causative factors for seizures, there's a whole host of reasons of why people can have seizures. These causes can vary by age or by precipitating event. There can be trauma, disease, a lot of different things. You can see on this list, certainly non-inclusive, but it can be drug overdose, hypoxia, vasovagal syncope can often present with seizure-like activity, local anesthetic overdose. There's a lot of different reasons as to why people can have seizures. We'll start with partial seizures, and really what we're talking about is electrical activity or discharges that are confined to specific parts or components within the brain. And so these are subcategorized as either simple partial seizures or complex partial seizures. Simple partial seizures really only affect one area, and so they're going to have the signs and symptoms that we'll see are really the specific motor or sensory symptoms associated with the area that's impacted, and really only that area. With complex partial seizures, now we've got basically multiple components that are affected, but it's not global. It's just it's basically two or more particular areas. So oftentimes these can present as hallucinations or auditory, irregularities, things like that. Next, we'll talk about generalized absent seizures. These used to be known as petit mal seizures, and typically these are very short in duration, usually less than 30 seconds. And they may occur frequently, they may be relatively infrequent. It just kind of depends on the particular patient. In terms of the physical findings, this is kind of a unique seizure-like activity because it's got a relatively quick onset. There's really no prodrome or cues that it's going to happen. And we really don't see the classic tonic-clonic muscular activity. Essentially what we have here is an alteration in consciousness where the patient essentially is going to stare off in space and they're really unresponsive for a very brief period of time, and then they kind of come back to normal. And oftentimes they're fine afterwards, and then they can have another one right away. It just really varies depending on the patient. Next, we'll talk about generalized tonic-clonic seizures. Once again, this is kind of the classic seizure activity that you think of when you hear a patient's having a seizure. This used to be known as a grand mal seizure. It's found in about 90% of epileptic patients, and typically the seizure-like activity involving sustained muscular contraction and relaxation lasts a lot longer than the generalized absence. These generalized tonic-clonic seizures usually last around 2 to 3 minutes. They seldom, though, last beyond 5 minutes, but they can. And it can take some time afterwards for these patients to really kind of come back to normal. Sometimes it can take up to 2 hours or so. And really, this is defined in two distinct phases. We've got the tonic-clonic movement, the tonic movements and then the clonic movements. So the tonic movement is really sustained muscular contraction, usually involving the whole body, where we see especially the muscles of the trunk, and they contract down, and so we see this kind of arching of the back, and it lasts for about 10 to 30 seconds, maybe 20 seconds or so. And then this is really followed by the clonic or the intermittent kind of muscular relaxation contraction component, where we see the shaking that kind of occurs. And so you can see the difference in the two phases over on the right-hand side. Now with status epilepticus, as I mentioned, that's defined as continuous seizure activity or repetitive recurrences of any types of seizures without any recovery between attacks. And this is really where we have seizures lasting over 5 minutes. And by definition, it's a life-threatening emergency. And if you're wondering, well, why is that a life-threatening emergency? We'll look at why that is. Remember that when we have sustained seizure-like activity, especially generalized tonic-clonic seizure-like activity, we get uncoordinated muscular contraction involving the whole body, and that's going to set up a couple different problems. Number one, we have all that increased muscular activity going on, and so the patient's muscles are really chewing through oxygen very, very quickly, and so they're quickly going to deplete the oxygen stores in the patient's blood. The other thing is that uncoordinated muscular activity, when it's occurring, it means that we don't have regular breathing going on. So essentially, these patients aren't effectively able to be, or aren't able to be ventilated, or they're not basically able to breathe on their own very well. And so that's another reason why they can quickly become hypoxic. Also, that increased muscular activity really sets up a hypermetabolic state. They're going to become tachycardic, they're going to be at risk for dysrhythmias, they are often hypertensive, they can be diaphoretic and hyperthermic. And so all that's going to lead to increased metabolism involving oxygen, which is going to further deplete their oxygen stores. And so they're really at risk for hypoxia. Now, the tonic-clonic seizures typically have a prodromal phase where the patient will often report some sort of visual alterations or aura, where they can kind of have a sense or hint that, hey, I think I'm getting ready to have a seizure, and that usually is due to the changes in the sensory perception. That's followed by a pre-ictal phase, which is really where we have the onset of unconsciousness. That's where we have the myoclonic jerk, and then that's usually that kind of intense arching of the back as all the muscles kind of contract. Oftentimes we'll have kind of this epileptic cry, whereas the diaphragm contracts and the laryngeal muscles contract. We get expulsion of air through the vocal cords, and that's heard as this kind of cry. This is really where we start to see alterations in the autonomic system as well. We see an increase in heart rate, increase in blood pressure. Often the bladder empties at this point, and this is really where they start to become apneic. That moves us into the ictal phase, which is the tonic-clonic component. That's where they're having the relaxation, contraction, those kind of jerking movements. Usually it lasts less than 5 minutes. Certainly if it's lasting that long, then we need to intervene and breathe for the patient as best we can. After the ictal phase is the post-ictal phase, and this is where they're essentially the muscular contraction component stops, and the patient's really just kind of wiped out at this point. Initially, they're often unresponsive or kind of comatose, especially if it was a really, really long seizure. And then gradually with time, the consciousness, it'll just kind of return on its own. Oftentimes, patients are really confused at this point because they don't have any understanding of what was going on because they were unconscious while the seizure was going on. Oftentimes, we'll see muscular flaccidity, and this is where they can be incontinent. Both urinary and fecal incontinence can occur at this point too as well. And essentially they're just super, super wiped out. And if you think about what they just did, they were really tensing up all their muscles in their body for, several minutes. It's that same kind of feeling you would have if you did a super, super intense workout, immediately afterwards. You're just going to be physically wiped out. And that's kind of how these patients are. So in terms of seizure goals and prevention, one of the things we want to do is really take a good medical history. We're trying to identify, how severe the patient's seizure activity is and how severe or likely they are to have a seizure during the dental treatment. And then you want to make sure that you're prepared for the possibility of a seizure. All right, we want to certainly consider preoperative sedation. That's going to decrease the likelihood of the patient having an intraoperative seizure because it's going to increase the seizure threshold. So, they're less likely to have a seizure intraoperatively. In terms of seizure management, we can look at, from a procedure standpoint, we want to keep them away from any sort of hazardous items. While they're having an actual seizure, we're going to get all the sharps away from them so they don't, hit their hand or cut themselves or anything like that. If you're worried about them falling out of a chair, then we can gently lower them to the chair. Otherwise, they can stay in the dental chair as long as they maintain, are well contained there. If the seizure activity is not breaking after a couple minutes, then we're going to initiate BLS protocol with our main goal there of maintaining an airway and ventilating the patient as best that we can. We'll try to monitor vitals if at all possible, and certainly if you're worried at all about the seizure-like activity occurring or not breaking, then you want to go ahead and activate EMS, especially if the patient's unstable or has never had a seizure ever before. In terms of what we can do from pharmacologic standpoint in terms of intervening, really what we're going to consider is administering any sort of our GABA agonists. So, our benzodiazepines are going to be a good go-to here, things like Valium or Versed, and we're going to deliver those via intramuscular injection. It's going to have a relatively quick onset. Certainly it's not as quick as intravenous, but if you have an intravenous catheter already in place, then that's fine. You can go ahead and administer your benzos that way. Alternatively, we could administer barbiturate. That's another option as well, but people really don't have barbiturates in their office, so benzos they're more likely to have benzos, so that's what we're going to reach for. Next, we'll talk about asthmatic attacks. Asthma is, as you're well aware of, is a very serious reaction involving the distal airways. In terms of children, we see an increased prevalence, and typically the onset and recovery really varies. It can be relatively quick or relatively slow. It really just kind of depends on the patient. In terms of prevention, really what we're looking for here is knowledge of the patient's past medical history. And you're going to spend some time and really ask some questions to try to elicit how severe or how at risk this patient is in having an intraoperative or perioperative asthmatic attack. One of the things we certainly want to do is make sure patients bring their own medication. That does two things. It allows us to have the medications readily on hand, and it also allows you to assess, how compliant the patient is. If they don't have any medications with them and they don't even have any at home, then that gives you a pretty good indicator that maybe this patient's not as well controlled. Looking at the predisposing factors, there's a variety of different factors. It really, once again, depends on the actual patient. We can see noxious odors, physical stress, dust fumes, allergic reactions. All these things increase the likelihood or potentially can increase the likelihood of the patient having an asthmatic attack. It really, once again, just kind of depends on the actual patient. In terms of what we see from a physical standpoint, with any sort of asthma attack, we're going to see a decrease in the lumen size, increased mucus production, and inflammation, and so the patient's really going to have difficulty moving air. We're going to hear wheezing, especially if they're able to move some air. If they can't move any air at all, we may not hear any wheezing, but they're really going to display a real difficult time breathing. They're often going to become red in the face. They're going to become sweaty. They're going to become typically very anxious while this is going on, and if it's really severe, they can even become cyanotic. In terms of management, our main goal here is to administer medications that are going to reduce stress and also fight the symptoms that we see with asthma. We're going to help administer our beta-2 agonist, which is going to cause bronchodilation. We're going to potentially even maybe administer things like epinephrine to help activate those beta-2 receptors and cause bronchodilation as well. I really recommend pre-medicating with a bronchodilator when indicated. If the patient's complaining at all about tightness in their chest or feeling like, well, I may be a little tight, I think I may be having an asthmatic attack or going to have one, go ahead and have them use their inhaler. If you're really worried about them, take a listen to their lungs. If you hear any wheezing, go ahead and have them use their bronchodilator. If they're having an asthma attack intraoperatively, the first thing we're going to do is go ahead and stop the dental treatment. We'll go ahead and have our assistants grab the supplemental oxygen. We're going to reassure them while we go ahead and get our bronchodilator on hand and use that. We'll get them in a comfortable position and then monitor their cardiovascular and respiratory status. Be ready to intervene as needed. In cases where the patient's really starting to deteriorate and you don't feel comfortable treating it, you think it's beyond your scope, then certainly have a low threshold for activating EMS. Some other pharmacologic interventions that we can use. Oxygen really is indicated, and it's really based on the severity of the attack. If it's just a very, very mild asthmatic attack, a little bit of tightness, and the patient's otherwise doing fine and has no symptoms, and reports, I feel okay, just a little tightness, maybe you don't need the oxygen, but it certainly doesn't hurt anything. Our bronchodilators are going to be our main weapon against asthma. Certainly albuterol is one of the main drugs that we use. That's our nice inhaled beta-2 agonist, and you're going to have the patient take a couple puffs. Remember that the albuterol actually has to get into the lungs themselves to actually work. And certainly we can consider epinephrine in really severe cases. You can see our dosage would be 0.3 milligrams. 0.3 milligrams intramuscularly for an adult, or 0.1 or 0.15 milligrams for a kiddo, and that happens to coincide with the dose in an EpiPen for an adult and an EpiPen Junior for a kiddo. Some secondary management techniques would include administration of longer-lasting beta-2 agonists, things like terbutaline, which is administered subcutaneously. Also, we can consider hydrocortisone or prednisone. These are some of the other medications that are considered, are often given, in the ER to help fight the signs of inflammation. But the prolonged onset of both of these drugs really doesn't make them ideal for acute primary interventions. This is more secondary interventions. Next, we'll talk about airway obstruction. As I mentioned, airway obstruction is one of the main causes of respiratory issues in sedated patients. But here we're looking at not soft tissue obstruction, but this is more of how to manage someone who you think aspirated an object. So the first thing we're going to do is, if we think the patient, either aspirated or swallowed, a foreign object like a tooth or a crown or etc., we're going to sit the patient, or we're going to place the patient in kind of a lateral decubitus position and encourage them to cough, to try to cough up the object. If the object is retrieved and they're doing well, maybe you don't do anything. But if you're worried at all, then maybe you want to initiate getting a consultation. Really just kind of use your judgment. If the object's not retrieved, then the question is, did the patient swallow it or did they aspirate it into their lungs? And so at that point, we're going to have to go ahead and consult with an ER or a radiologist to obtain a radiograph to look for the object. If the object is in fact in the lungs, then they're going to have that surgically removed. Typically what they do is use a bronchoscope which is passed down into the lungs and has a little hook or basket on it, which is able to visualize and then retrieve the object. Now, if the patient becomes unconscious or is unconscious, then what we need to do is quickly perform the Heimlich maneuver. So we can use abdominal thrust if the patient's on the floor. And you guys all know how to do the Heimlich maneuver. Moving on, we'll talk about chest pain and how to manage that. In terms of the etiology of chest pain, remember that not all chest pain is cardiac in nature. It depends on really what the underlying issue is. And so what you kind of need to do is put on your detective hat and figure out what's going on. Determine, is it musculoskeletal in nature? Is it because, they got punched in the chest? Or they, were working out and kind of overdid it and it's their pectoral muscles that are sore? Is it chest pain because of respiratory difficulty, meaning they're having an asthma attack? Or is it acid reflux? These can all kind of present as chest pain. Now, certainly if it's none of those, and you're certainly worried about, especially with a history of cardiovascular disease or coronary artery disease, then yeah, they can have angina or acute myocardial infarction. So, certainly those are on our differential list. And really what we're trying to do is figure out what we think it is. In terms of angina with precipitating factors, anything that's going to increase the stress on the heart, so physical activity, emotional stress, caffeine, fever, anemias, all these are going to increase the stress on the heart and decrease the ability of or kind of upset that oxygen supply and demand. So the physical findings that we see with angina, typically the patient is conscious and they're going to report this acute substernal chest pain. Oftentimes it can kind of radiate down their left arm, it can radiate to their back or jaw, and it can be different for each patient, and it can even be different between men and women. The two different main types of angina are stable and unstable. With stable angina, essentially what we have here is kind of an upsetting of that oxygen supply and demand, but it's more on a chronic basis. Typically, it's a duration of 1 to 15 minutes, and it responds well to nitroglycerin. So whenever we're able to reestablish in a positive direction that kind of supply and demand and give the oxygen or give the heart plenty of oxygen, So in terms of treatment of angina, we want to take a good medical history, elicit whether or not this is new onset, unstable angina, or is it just the same old, angina that they always have, i.e. stable angina. If it's the same old angina they always have, then and it's right in the middle of the dental procedure, then what we need to do is stop the dental procedure. We're going to watch them, get them in a comfortable position, give them oxygen, give them nitroglycerin, and then really just allow them to kind of calm down and reestablish that positive balance between the supply and demand of oxygen for the heart. If it's new onset and something different, remember this would be by definition unstable angina, then we need to get this person help, and we need to get them help now. So we're going to stop the dental procedure, immediately call 911. While 911's on the way, we're going to get them in a comfortable position. We're going to initiate BLS and monitor vital signs, and then we're certainly going to consider initiating our MONA therapy. That's morphine, oxygen, nitroglycerin, and aspirin. So here's the kind of flow chart for angina as to whether or not it's stable angina or unstable angina, and kind of the response that we're going to do. So at this point, let's talk about a myocardial infarction. An MI or acute MI is the leading cause of death, and it's responsible for well over 1 million Americans die from an MI per year. It's responsible for about 35% of deaths for men between the ages 35 and 50. And you can see that as patients age in the U.S., that's going to increase the likelihood of them having a myocardial infarction. Roughly 1 in 5 U.S. males has a chance of having an MI prior to the age of 65. So the highest risk population in terms of who's high at risk would be males over females. Usually they're over the age of 40. If they've got a family history of coronary artery disease, that's going to increase the likelihood of them having an acute myocardial infarction, especially if they've got a lot of the lifestyle risk factors go along with that, such as sedentary lifestyle, poor diet, if they smoke, if they don't exercise, if they have a lot of other comorbidities such as diabetes, hyperlipidemia. These are all going to increase the likelihood of them having an acute myocardial infarction. In terms of management, management is really based on a quick recognition and then application of our basic life support principles. So there's a really subtle difference between acute, new onset or unstable angina and acute MI. The physical findings that we tend to see are very similar. We see chest pain and angina, but once again with this, nitroglycerin does not help, either does rest. And they report, really a severe, intense pressure in their chest. Often they report that they have almost like an elephant sitting on their chest. They can also report like an impending sense of doom. These are all cues that the patient may be having a heart attack. Once again, we see that pain radiating to the left arm, jaw, or back. Really can vary amongst patients and between sexes as well. In terms of treatment, once again, we need to get them to the hospital as quickly as possible. So really early recognition and diagnosis. I would have a very low threshold for calling EMS for a patient that reports, chest pain, especially if they've got all the classic signs. Once we activate EMS, we're going to terminate our dental procedure. We're going to get them into a comfortable position, monitor their heart and vital signs. And then we're going to do our MONA protocol: morphine, oxygen, nitroglycerin, and aspirin. So in terms of what these agents do, for morphine, remember, one of the unique things about morphine is that it does cause some histamine release. And so not only do we get the analgesic effects of morphine, but because we get that release of histamine, that's going to cause some vasodilation, which actually is helpful because it's going to vasodilate the coronary arteries, and we may get some additional blood flow to the infarcted or ischemic area, so that can really help. The analgesia that's produced with the morphine is also going to reduce the pain the patient's having, which is going to lower the sympathetic nervous system activity, which is going to, once again, reestablish kind of in a positive light that balance between supply and demand of oxygen for the myocardial tissues. We're going to administer oxygen. Ideally, if we've got a full face mask that allows to really give 100% oxygen, you can consider using nitrous oxide with oxygen, because remember, you're going to give additional oxygen with the nitrous oxide as well. And there's some analgesic effects from the nitrous oxide, so if you got it, you consider that as well. We're going to certainly consider our nitroglycerin to help cause some vasodilation of the coronary arteries to reestablish blood flow. You can consider 0.4 milligrams sublingually up to 3 times. And then we're also going to consider administering our aspirin. Remember to have 325 milligrams. We're going to have the patient chew that to increase the onset. And it's important to understand that while it doesn't decrease the size of the thrombus already formed, it does prevent the increase in that clot, and hopefully can increase any or decrease the risk of any additional artery occlusion. Let's talk about stroke for a little bit. A cerebral vascular event or stroke is relatively up there in terms of causes of death. You can see there are about 600,000 new cases of a stroke that occur annually in the United States. It's the third leading cause of death right after acute myocardial infarction and cancer. The average age you can see occurs right around 65 years, 64 years, and it's really the most common form of brain disease. And I really think that one good way to think about that is that's kind of like a heart attack, but for the brain. In terms of the pathophysiology with a stroke, remember that the brain, just like the heart, is in a constant need for oxygen, and anything that's going to disrupt the blood flow is going to disrupt the oxygen delivery. And so, if we disrupt the oxygen delivery, then the nervous system tissue is going to start to die. The other thing is that the brain does not have the ability to expand and swell because it's contained within a bony space, the skull. And so if we have an injury to the skull or to the brain, that can lead to swelling, and that's going to, basically the swelling, we're going to have an increase in pressure, and that can decrease the blood flow simply because of the pressure, the increase in intracranial pressure. In terms of the etiology, if we have an infarction of the tissue in the brain, we're going to have a decrease in oxygen delivery that's going to lead to ischemia and then infarction and ultimately cellular death. There's a whole lot of predisposing factors, and all these really increase the likelihood of disrupting blood flow to the brain. There's two main types or categories of a stroke. There's occlusive and then hemorrhagic. Occlusive is the most prevalent. It accounts for roughly 4 out of 5 cerebrovascular accidents. And then once again, this is kind of like the brain attack, kind of like the heart attack, where you have a clot, but the clot is lodged somewhere in the arterial blood supply in the heart or in the brain, and essentially all of the tissue that would be perfused distal to that clot is not able to receive blood flow, and so it's going to die. The other type is hemorrhagic, and this is where we have a bleed, and then we have like a leakage or bleeding out of the artery, and then into the neural tissue, and then basically once again that's going to start to impact or squeeze the neural tissue surrounding that clot. As far as the physical findings that we see with a stroke, we're going to have an alteration in consciousness. We'll typically see, maybe even seizures. They'll become confused. Patients can report a really intense or severe headache. Oftentimes, we may see really poor coordination, or they can develop or display facial muscle weakness. Typically, it's one side or the other. They can report visual loss, or they can have really slurred or indistinct speech. So all these are kind of clues that they may be having a stroke. In terms of treatment, we certainly want to know our patient and identify the risk factors ahead of time. If they're hypertensive and they've got a history of a stroke, that's going to increase the likelihood of them having a stroke intraoperatively. If we're at all worried about them having a stroke, we're going to initiate EMS very, very quickly. And then we need to get monitor them and support them as needed. And we'll talk about the 7 Ds of a CVA. The 7 Ds of stroke care really, what they are essentially is detection. We need to be able to quickly identify the problem. We need to dispatch. We need help. We need to get EMS activated as quickly as possible. The next is delivery. We need to get them to the hospital as quickly as possible. Ideally, we want them seen in the hospital within an hour of the onset of symptoms. We need to get them to the door. That means it's kind of like another means of delivery. The next is data. That's where they're quickly scanned, usually involving either an MRI or often than that, a CT scan, which will look at the intracranial components. We're going to quickly diagnose whether or not it's an occlusive stroke or hemorrhagic stroke, and then we're going to consider the drug therapy accordingly. For an ischemic stroke or occlusive stroke, we can potentially consider the use of fibrinolytics, but it has to be initiated within 3 hours. So that's one more reason why we need to identify these patients and get them care as quickly as possible. Moving on, we'll talk about diabetes mellitus. Diabetes is extremely prevalent. It affects about 200 million individuals worldwide, and it's extremely prevalent here in the United States. It affects about 15.7 million Americans, and I think that number is rapidly growing even as we speak. It's the 7th leading cause of death, and I think that's starting to increase as well. And there's a lot of complications that can arise because of diabetes mellitus. We can have chronic and acute complications. With chronic disease, we see more issues impacting the global body as well, essentially. We can see changes within the vascular system, within the kidneys, within the eyes, the skin, the mouth. It can be an issue with pregnancy as well. Acute complications typically are discussed would be like hyperglycemia, and it can even be diabetic ketoacidosis, or DKA. That's typically reserved for type 1 diabetics. And then we can also have issues regarding where their blood sugar is too low or hypoglycemic. They can be essentially even unconscious. So let's start with diabetic ketoacidosis. Really what we have here is a situation where they're lacking insulin, and their body is not able to utilize the glucose effectively. Typically, we see a gradual onset with this. We tend to see really dry skin, flushed skin. They're really confused. They can have this really distinct kind of sweet breath smell, and that reflects the ketone bodies because that are produced as their body. The metabolism shifts away from utilizing glucose and basically shifts more towards the utilization of proteins and fats. And they have this distinct kind of Kussmaul breathing where they have really deep, irregular, regular sighing respirations. They're often disoriented, and they can even be in a coma. It's very unlikely that we're going to see DKA in the dental office. It just tends to not really occur that prevalently in a dental office. But certainly if it's suspected at all, we're going to stop dental treatment. We're going to get them to the hospital as soon as possible. The one situation where I could essentially see this arising in a dental office is when they first present in the morning or in the afternoon, when you first see them, and you're going to identify that they just don't quite look right. So if we're all concerned about that, we're going to call 911, initiate basic life support, consider an IV placement, and then monitor them until EMS shows up. With hypoglycemia, typically we're going to see blood glucose levels less than 60 to 70, and it's really kind of a patient-by-patient basis. And the symptoms that we tend to see nervousness, confusion. They can become diaphoretic, tachycardic. They can even have seizure-like activity, or even become unconscious or kind of like coma-like activity. And the issue here is that a lot of these symptoms, if you think back to some of the other conditions we've talked about, a lot of these symptoms are very similar for them as well. And so it can be somewhat difficult to determine whether or not the patient's having a hypoglycemic event, or are they, having a vasovagal reaction, or are they hyperventilating, etc., because a lot of these symptoms are kind of similar. In terms of the etiology of hypoglycemia, really it can stem from a couple different reasons. They can, have not eaten anything. That's one of the common reasons we see. Maybe they've overdone the exercise, but typically it's that they've had some sort of insulin overdose combined with a lack of nourishment, or they've overdone their oral hypoglycemic medications, their sulfonylureas, where they've got an increase in insulin production, and that's going to rapidly drop their blood sugar, and then voila, now they're symptomatic. So in terms of managing these patients, one of the first things we need to do is identify what's going on. We're going to do that by checking a blood sugar. So you can do that very quickly in your dental office. And if you draw the patient's blood sugar and look at it, and it's below 60 to 70, and they're symptomatic, I would go ahead and presume that this is potentially a hypoglycemic event, and you're going to initiate the proper protocols and correct that. Then if the symptoms continue, then you can look at something else as being the causative factor. Some other management things that we can consider in terms of prevention, make sure that you treat your diabetic patients in the morning. You can tell them to eat breakfast, assuming they're not a sedation patient, and make sure that you discuss with them that you want them to take their meds like normal. Evaluate what their blood sugar is and adjust their insulin accordingly. Some of the questions that you certainly want to consider with your diabetic patients: inquire the last time you ate. Did you take your medications this morning? Did you check your blood sugar? What was it? Get an idea of what their blood sugar normally runs. Determine what their A1C is. Just kind of get a sense for how controlled they are. In terms of hypoglycemia treatment, remember our goal is to rapidly raise the blood glucose. We can do that a couple different ways depending on the situation. In addition to that, we're going to stop the dental procedure, get them in a semi-reclined position, initiate BCLS or BLS and airway management as needed. Monitor their vitals. We're specifically going to evaluate their blood glucose. If we identify that it's low, we'll intervene. And then you can consider activating EMS. Really just use your judgment once again. If you don't feel comfortable with the way the patient's heading, then certainly, have a low threshold for calling 911. Now, in terms of correcting their blood sugar, we've got two different scenarios here. One is if the patient's conscious, then you can give them either some sort of oral nourishment. You can give them oral glucose like Instaglucose. You can give them cake icing. You can have them drink some orange juice or some Coke. You certainly want to make sure that you stay away from any sort of diet sodas that doesn't have any dextrose in it, so that's not going to fix the problem. But we're giving them some sort of oral nourishment with sugar in it. That's going to have a relatively quick onset. They'll start to feel better in about 15 to 20 minutes or so. If they're semi-conscious or unconscious, though, the last thing we want to do is put some sort of foreign object like cake icing or fluid in their mouth, because they can aspirate that. So if they're unconscious or semi-conscious, really now we're looking more towards intramuscular, intravenous dextrose. And so you could consider this is 50% dextrose, so it's very concentrated, and we can administer that either intravenously or intramuscularly as needed. All right. Thank you for listening. If you have any questions, please contact me via email. Thank you very much.